Good morning. I am not Dr. Steven Stites. I'm Dr. Sean Coomer, transplant surgeon and chief medical officer here at the University of Kansas Health System. Welcome back to Open Mics. A patient living with chronic liver disease learned a complete stranger was going to change her life. Today, we're going to show you the science making that possible. But first, here's the remarkable moment an altruistic donor offered the gift of life.
I just was pretty fatigued. My skin became very sensitive, and so I could only wear or touch certain fabrics of clothing, bedding, blankets.
For the past 10 years, Christina Schadeg's autoimmune disease has progressed. It started with really bad back pain. After having kids, it seemed to get better, but that didn't last.
We did a liver biopsy and it confirmed primary biliary cholangitis.
Primary biliary cholangitis is an autoimmune disease that causes damage to the bile ducts. It can lead to inflammation and damage of the liver. Doctors started Christina on medication. It helped the back pain, but the PBC progressed.
And there's a lot of things that I used to go to K-State football games and farmers markets and just go do things. And now I just think of how much they'll wear me out. Just an overwhelming sense of fatigue will just hit me and I can't do anything. I will have to sit down, I'll have to lay down. It takes a day or two to recover. It's almost like having a hangover when you're older. It takes longer to recover.
She was referred to hepatologist Dr. Ryan Taylor at the University of Kansas Health System. He explained to Christina that she would now need a liver transplant.
The organs out of the body as least amount of time as possible.
She met with transplant surgeon Dr. Tim Schmidt, and the search for a donor began. A transplant would mean this once very active mother would have a chance to get the life that she loved back.
Well, we're doing a living donor liver transplant. Yeah.
Christina didn't have to wait long. An altruistic donor, someone Christina didn't even know, offered to donate part of their liver.
When Dr. Taylor called and told me that there was an anonymous living donor, it was pretty special. I'm excited. I'm just thankful and ready to do this. And yeah, on the other hand, I'm pretty scared and terrified, but I feel like the team here is very good.
Making the gift even more incredible, the anonymous donor had already given their kidney to save a life and was now donating part of their liver to save another.
That's truly amazing that somebody is so selfless that could do that, could come and just say, I want to help somebody. It's just kind of given me the future back. It's so amazing.
And today, Christina shares her gratitude and proudly wears her story as a badge of honor.
It's the liver ribbon. I feel like that is very statement-oriented to my life because I need to not focus on what I have. I'm here, I need to live my life, and I have this, but I'm also here and I'm going to do it.
It's with great pleasure we welcome the star of the show, Christina Schadeg. Thanks for being with us. Along with our transplant hepatologist or liver doctor, Dr. Ryan Taylor, and transplant surgeon, Dr. Clay King. Christina, how are you feeling today?
Pretty good. Pretty good.
Yeah. You were receiving treatment prior to the living donor liver transplant. You managed taking medication. How much did medication help with before the transplant?
It helped, but it got to the point where we just kept adding more to try to get this thing, the side effect of this medication, and it was just all kind of Band-Aids. Mm-hmm. And so it was helping, but not enough.
Yeah. So when did you realize your disease was progressing despite the treatment?
I think it was about 2021 in the fall that it started to just amp up and progress, and then by January of 22, it's when we started talking about a transplant.
Okay. Well, Dr. Taylor, PBC is an autoimmune disease. What's happening at the cellular level when the immune system attacks the bile ducts?
So your liver is one of the things it does is make bile, which helps your body with digestion. And when you get PBC, your body has trouble clearing that bile out naturally, and so the bile ducts can get damaged, and then that is very corrosive to the liver and can eventually cause bile duct scarring and loss, which can lead to a lot of symptoms and eventually liver fibrosis and cirrhosis.
And Christina, when you got the news that an anonymous donor had stepped forward, what was your initial reaction to receiving part of someone else's liver?
I think shock, like I didn't really register right away what was actually going to happen. It took a couple weeks before I really kind of registered that, and then it was just a whirlwind of excitement and being terrified at the same time.
So from the time that you were told you had a liver transplant till the time you were told you have a donor potentially, how long was that?
About 3 years.
About 3 years?
Yeah.
Did you expect it to be longer or shorter, or what was your thought about that?
I wasn't sure, just because I was hovering at kind of a low 20s MELD score for such a long time that, and then when they talked about living donors, I just didn't know who to ask, because I didn't want to put any of my friends or family out, and so they wouldn't be able to spend time with their family and their kids or lose work or anything like that. So it was pretty amazing that I didn't have to do that, and somebody actually just stepped up and did it without any care for themselves, really. No,
That's amazing. So you mentioned the MELD score. The MELD score, for folks out there, is really just a way for us to gauge how sick the liver is. It goes from 6 to 40 by some crazy algorithm equation, and the higher the number, the sicker folks are. So with the low 20s is probably, we transplant folks deceased donor-wise with a lot higher number than that. So you weren't really coming up on those matches. So Dr. King, deceased donation is more familiar to our people out there, but there's a great need for liver donations. Right now, 24,000 people are on the wait list. What are some common reasons living donor liver donation lags behind? I assume it's not one reason, and it's not all transplant programs but that offer living liver.
Yeah, I think that's the main thing, is you got to have support from your institution, and it's a large undertaking. I'm sure there are plenty of programs that would like to be started, that have deceased donor programs, and we were just very fortunate we were unfortunate at the same time. It was need-based. Our liver transplants, I don't need to tell you, we went down 50% after 2020 with kind of the reallocation of how deceased donor organs were moved across the country, and in that time our wait list increased drastically, and she was one of them on there for a long time. And so I think the real reason that it's not happening more is just because it's such a large undertaking, and some places are using other strategies to try to increase their numbers, and we're trying to increase our numbers the same way, and this is just one way to go about it.
Right. Can you explain how living donor transplantation works, particularly the liver's ability to regenerate in both donor and the recipient?
Yeah, it's you're quite petite, so you got to have a certain amount of liver to be donated to Christina to be able to function and recover from the surgery, and there's a little bit of a buffer zone there. And then for the donor, you got to make sure they have enough liver left behind so that their liver doesn't struggle afterwards, and then both parties will have increased size of what is remaining. And so for Christina, her right lobe graft didn't grow a left lobe, it just increased in size, in the same way for the donor.
So we want to show you what Christina's liver looked like. This is what was removed during her transplant. Dr. Taylor, you can see the liver as a brownish color. What are we seeing here?
That's just the bile pigment that's built up from not being drained properly from her liver. So it really has had a very darkened appearance there from all that buildup.
So what does a healthy liver look like? Is it similar in color? Is it different? What does it look like?
It's a little more of a nutmeg color, so I know we're kind of gingerbread color, if you will, if it's a healthy looking liver where it's Christmas season. So gingerbreads are on everyone's mind, so it's a little bit lighter tan, lighter brown color.
Yeah, and you can see in those pictures there that the left is the diseased liver, and the one there on the right is the partial liver graft, the living donor liver. So you can see a little bit different color there. Dr. King, Christina's donor is anonymous. What are the safeguards when approving an anonymous individual to donate their liver?
Yeah, I think regardless of why somebody comes forward, you have to figure out and make sure that the reasoning is safe and non-coerced. And so the safeguard there for the donor is every patient that wants to donate or even considers donation of liver, before we even do any sort of medical workup, they go through an independent living donor advocate. And so that's a go-between in the middle that kind of takes the entire story of why somebody what motivations somebody has to donate their liver. And so for this particular case, it's just vetted through that, making sure that there's no coercion.
Okay. There's new research on living donor liver donations. In August, the American Journal of Transplant published a longitudinal study that showed encouraging results on the long-term safety of living liver donation. The study looked at nearly 9,000 living liver donors, that's a tongue-tied right there, in the United States over 3 decades, and found deaths within 90 days of donation are extremely rare. 8 people out of nearly 9,000 people, which is 0.1%. The research also determined donations made after 2007 were 9 times safer than those prior. Dr. King, donor deaths have dropped dramatically in the past 30 years. What's driving that improvement?
I think one is looking at the numbers. There's not a large number of donors every year, so I think about 600 in the last couple of years is the total living donor liver transplants, even though the number of total liver transplants has increased every year to over 10,000 and 11,000 last year. So I think there's a small number, so even reducing that number by just a few is a drastic change. And so I think donor safety after 2007 is probably largely related to just how much technology has aided in ensuring safety. And so 3D reconstruction and modeling of the imaging that we get, and so even the imaging modalities have improved, and then the way that we can kind of merge those 2 different modalities. And so for Christina's donor, they would undergo an MRI to really look at the bile ducts, because the bile ducts can be a big problem in living donor, and then the vasculature and everything is merged together. And so we're making we get a nice idea of what the right side is going to look like that's going to be transplanted, and the left that'll stay. And then additionally, the really accurate volume assessments, because again, we need enough for Christina, we need enough for the donor to remain. And the volume metrics are the 3D renderings, and how you can make sure that those are much more accurate than they were even just 5-10 years ago.
And it should be pointed out, you went through specialized training to do a lot of this living donation.
Yeah, it's a totally different ballgame. I think the rationale for having to make the program work was one thing, and then figuring out how do we even become a living donor transplant center was another. And we had really nice support from Intermountain in Salt Lake City. They were kind of partnered with us to kind of help our logistics, and then the training of it. Really, Dr. Rella in Chennai, India, I went and studied under him for 6.5 weeks, and that was a remarkable experience.
And Dr. Taylor, although living donation is much safer, what are the biggest short-term risks to living donors? What do they face in recovery?
Yeah, they, obviously are putting their body at risk to do this. So one of the big things that can happen is there can be bile leak. So if you remember, you cut through the liver, which is a very vascular organ and has these bile ducts there. So those can leak after surgery. You can have bleeding as well. Obviously, the surgery team does everything possible to try to minimize that, but that can have a big consequence. And then, of course, patients are going to have postoperative pain. It's a large incision that patients get, and have to go through that recovery process.
So Dr. King, with the safety improving, we feel confident in recommending living liver donation. So our donor in this story is anonymous, but what is required to be a living donor, and what are the steps to get there?
So the first step is either knowing somebody, I guess, or in this case, not knowing somebody, and just feeling compelled to do so. And so calling our transplant center, you will be directed to our living donor coordinator, Emily Kuser, and then then you're going to be the donor, the potential donor, will go through the independent living donor advocate before we bring them in for a formal, physical exam, labs, and imaging on a day where they meet, or 2-day process where they meet several different specialties in medicine.
Yeah. Christina, can you tell us about the biggest adjustment for you in recovering from your transplant? What is on your bucket list once fully recovered is what we're getting at.
Well, so far, I feel like I've been able to get back to where I was prior and further, just because I was able to get back to work. And but I think the goal for me is to just be able to get through a week without having to spend the weekend resting, but then also to travel and be able to go back to going to K-State football games like we used to do all the time, and just not have to worry about how long we're going to be somewhere, and just all the things that I had to calculate before I could go do something before.
So it freed you up a little bit.
Yeah, yeah.
A lot of it.
Yeah.
Dr. Taylor, organ transplant includes managing the risk of organ rejection. Is the risk different for living liver donation compared to deceased? And how do you balance immunosuppression or anti-rejection drugs to prevent rejection while minimizing the risk of infection and malignancy that get lowered by taking some of those medications?
Interestingly, once you get out of the post-transplant window, the management is pretty much the same as someone who received a full-size deceased donor. So the medicines are the same, the algorithms are the same, every way we approach it is pretty much the same. So the medicines that Christine is taking is the same dosage and levels that we give with a standard patient. So, using immunosuppression is always like balancing too much and too little, kind of like putting salt in food, as I like to say. So you don't get too much, it ruins the food, or not enough, it doesn't work. So with the immunosuppression, we just got to find the right balance.
So are there promising biomarkers or immune tolerance strategies that might allow patients to use less medication over the long term?
And that's the holy grail for us in transplant, is to find tolerance, where someone can accept an organ from someone and not require medication. Still a ways off for prime time, but there have been studies and ways and strategies we've looked at trying to minimize the medication. The problem is it just requires very close monitoring, and one of the ways we would monitor sometimes is liver biopsy, and that's hard to do regularly, and patients don't obviously like to do that, but there is a percentage of people out there, I believe, that can require less medication and be successful.
Well, we're here to answer your questions. Please send them in using the info on your screen. That includes the chat on YouTube or Facebook, or emailing the Medical News Network. So let's check in with Doc Hawk. So Dr. Hawkinson, there's been a bit of back and forth with the FDA. It's now reportedly has no plans to put the most serious warning on COVID vaccines, going against earlier reports that it would add a black box warning. What is a black box warning?
Yeah, so first of all, I think that's a great question, like what is this, why do we need it? So it used to be called a black box warning. We still call it black box warning, but it can just be referred to as boxed warning as well. Basically, it is the highest safety-related warning or warnings for medications that are assigned by the FDA. And these warnings are really just used and intended to bring the consumer's attention to the major risks of the drug, but of course, the doctors that are ordering them as well. So medications can have boxed warning added or taken away or updated throughout their tenure on the market. And right now, it should be stated that there are over 400 different medications with boxed warnings in general. Typically, boxed warnings are for a particular drug cohort or a class of drugs, not necessarily just one drug. But this is because typically a class of drugs will have severe risk associated with the mechanism of action of that drug, and also its desired or undesired effects on the body. And so, therefore, it is typically just throughout that whole class of medications, because typically those medications will work in similar ways. So, but we would say that initial thought and want to put a boxed warning would be based on more of opinion rather than true scientific evidence and data. I think that cannot be understated. Although we know there can be a very small percentage of adverse events with mRNA COVID vaccines, there is an abundance of well-done, peer-reviewed studies supporting the safety and efficacy of the mRNA COVID vaccines. In fact, we also have a recent December 11th MMWR report, but also a December 4th JAMA Network Open report that shows that particular safety and efficacy. In fact, the JAMA Open Network was actually 28 million people. It was out of France, and it followed people for 4 years. Basically, what it showed was that the mRNA COVID vaccines showed 74% lower risk of death from severe COVID, but also throughout those 4 years, 25% lower risk of death from any cause at all. So, and then I think one more thing to support the safety and efficacy. If you remember in September, there was an announcement to stop recommending to COVID-19 vaccines for children and pregnant women. But on a scientific and medical basis, this is completely wrong. There are, again, multiple peer-reviewed, well-done studies to support the use of vaccines in pregnant women as well. And I would say that even now we have a most recent report, as most recent as December 15th, looking at COVID vaccines in pregnant women, and what it showed was that COVID vaccine was actually associated with a lower risk of maternal hospitalization and critical care unit admission. And importantly, it also showed a reduced risk of preterm birth in those people with vaccination as well. So I think all of this data support the continued safety and efficacy of mRNA COVID vaccines. And remember, we still have the VAERS, which is that system that anybody can link into and put any concern they have about any medication, including this vaccine. So that is an ongoing monitoring to look for safety signals as well. In general, again, I think it can't be understated, the mRNA COVID vaccines continue to be safe and effective, and we have an abundance of data to support that.
And so, you know, when it reaches black box, we've all read the side of any medication and says it causes 10 different side effects, which are usually very rare. But going up to a black box is even more serious, correct?
For sure, and this is when it is very important, as we all do, and that is communication with our patients and patients asking us doctors questions they may have so that we can answer them to the best of our ability. And it's determining, is this best for you, the specific patient, and what are the risks and benefits? And so, you know, we always support that, and this is one more thing to help us, you know, just keep an eye on if you do see a black box warning on a medication you are getting or you are going to prescribe, to have that open communication with your medical team.
Okay, so let's switch gears a little bit. Measles outbreaks are growing. Hundreds of people are now quarantining in South Carolina. Some of them are in quarantine for the second time since October. What's the biggest risk with measles, and how long does transmission last?
Yeah, I mean, well, the biggest risk, as with a lot of diseases, is certainly death. We know that 1 to 3 in 1,000 cases could potentially die, but there are also other risks associated. There can be significant ear infections, there can be pneumonia, certainly we know hospitalizations can occur. And that is just with the patient, but then if you look at that patient's family, what does that mean for the missed work days for those people? We know that, you know, in this time of affordability and everybody, a lot of families are just struggling. So can you take those missed days of work? But from a medical standpoint, there are those complications. In addition, especially if you are diagnosed with measles under the age of 2, if you are 2 or younger, you actually have a higher risk of what we call SSPE, which is subacute sclerosing panencephalitis. And this is actually a disease that you can get up to a decade after you are infected with measles disease, and it is a fatal brain or neurologic disease. So it is not a benign disease. The vaccines have caused significant reduction and really elimination in those complications. So I think it is important to continue to say that we have decades and decades of safety and efficacy profiles for those vaccines as well. It is unfortunate if any child does get measles, but hopefully we can start to stem the tide of the cases in the United States. Right now we're over 1,900, so this is more cases than we have had in over 2 decades, unfortunately.
Yeah, and I think we thought we had this eradicated in the early 2000s. It's come back, and the rise seems to be mostly because folks aren't getting vaccinated nearly as much as they used to.
Correct, yeah. It's nearly 100% preventable.
Great. Thanks, Doc Hawk.
Yeah.
Alexis Del Cid, watching for questions from our community. Alexis?
Good morning. We've got a great question from Jeremy Yenser. Jeremy wants to know, do different parts of the liver do different things? Do you need the donor to donate a specific part of the liver, or is it all the same thing?
Maybe you can start with that, Dr. Taylor,
Yes.
and then you can follow up. Is that all right?
Absolutely. So the liver function are with all the liver cells, so there's not localized areas that we can see. So it's, all comes as a whole. So there's not particular areas that we would carve out of the liver for someone.
And how about the certain parts of the liver that should or should not be donated?
Yeah.
Right or left?
You need enough bile duct, you need enough artery, and you need the veins to for the graft. And so for adult to adult, most people use right lobe grafts because there's enough volume for the recipient. In smaller patients, adult to adult, you can use the left lobe, but really it comes down to the safety of the donor and then feasibility of sewing that graft into the recipient.
Becca has a question, another question about how the liver works. She wants to know specifically, how does the liver regenerate after a donor gives part of their liver?
Do you want to take that, Dr. Taylor?
Sure. So the liver has an amazing capacity of their cells to regenerate, and so the liver can take a licking and keep on ticking, as we say. So the liver is very good at that. It just has the cellular machinery and ability to replicate itself very well. It's not perfect over time. If there is enough damage, there can be scar tissue that builds up. But for a patient like Christina, that liver can really regenerate very, very quickly and get to the mass that she needs to be healthy.
Dr. Taylor, how much of the liver can you remove?
That's a good question for Dr. Kane, but usually we're on the order of 50–60% max. Is that about right, Clay?
Yeah, really we needed to leave for the donor can give up to 70% of their volume.
Oh, wow.
We don't go over 70%, need over 30% to, but I think in Christina's case, that was about a 65–35 ratio from donated liver to remaining in the donor.
Jill has a question. She wants to know, because Christina has an autoimmune disease, if she will need another transplant down the road.
Unfortunately, PBC can come back. That is one of the issues with autoimmune diseases. Thankfully, it's the exception, not the rule. So we will have to monitor her, but most of our patients do well and don't have the disease come back and can lead healthy lives moving forward.
Marie wants to know, how do you keep her autoimmune disease from attacking her new liver?
So that would be the anti-rejection medicines that we give. So that makes your immune system lazy and not as aggressive. And so not only does that help prevent Christina's liver from rejection, it can also shut down some of the pathways that can trigger the autoimmune attack to the liver.
Janet has a question for Christina. She wants to know what life is like now with your new liver, if you have any limitations.
I think I'm still in the process of recovering. My biggest limitation is remembering that and not doing too much. But I think that the main symptoms would be, just getting back to being who I was before, and if that's possible, and just I'm more of a active person, and the lag time between when the diagnosis came about and to now, it's been hard to not just want to do everything, and so that kind of sets me back a little bit, but not physically.
Along those lines, Jane has another question for Christina on if you have any limitations. For example, can you take Tylenol or Advil when you have an ache or a pain? And she also wants to know if you're allowed to have a glass of wine here and there with a new liver.
I take Tylenol. I'm not able to take the ibuprofens or the Advils or anything like that. I haven't had any wine or anything like that, but I don't know what they would say to that.
Yeah, we would obviously discourage alcohol. You just don't want to in any way damage this new liver that's trying to heal and regenerate itself, and we just never know what a safe amount is, so the best way there is to avoid it and stay away from it.
Yeah. And the Advil situation is that some of the anti-rejection medications can be tough on the kidney, so you don't want to add to that if some of the Advils or ibuprofens.
Yes, just makes more kidney damage.
Right. Well, this has been a really great discussion. Want to get some final thoughts from our guests. Christina, you want to start us off?
I think the biggest thing is that I am so grateful for my donor and to just be selfless enough to donate their liver to help somebody else have a prolonged and enjoyable life is just amazing. And I wouldn't be in that situation without KU Med and Dr. Taylor really being an advocate for me. And then just having such a great team here, and the great surgical team, and Dr. King and Dr. Schmidt have been very supportive and very helpful, and I'm in a really good place with a really good support system. So,
Dr. Taylor?
Yes, this is a season of giving, and all of these amazing miracles of transplant help because of a donor and someone that gives the gift of life. So, you know, it's not everyone can be a living donor, but everyone can sign their donor cards for their license. You can have those conversations with your family in the event that something just unthinkable happens, what your wishes would be to be a donor. So, you know, none of this happens without someone having that forethought and ability and wish to help someone else.
Dr. King?
I couldn't have said it any better.
Okay. Well, yeah, I think that's really, it comes down to the donors are the heroes of many stories, and that being living donation as well as in deceased donation. So please keep that in mind. Speak with your family before doing that. So before we go, I want to go back to Dr. Alexis Del Cid. Alexis, you're sharing another transplant story tomorrow. Is that right?
We have an incredible story tomorrow, Dr. Coomer. It's so powerful. It's about a man named Robert Frias, who was diagnosed with heart failure here at the health system, put on the transplant list. He waited for months until he got the news he would finally get his new heart. And it came from a young girl in Texas, a teenage girl. You're going to meet Robert, see this incredible video from in the surgery room. That is video of him meeting his donor's father for the first time. It is all tomorrow on All Things Heart.
Well, thanks everyone for watching and listening. Remember, faith, hope, and science.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now, everywhere podcasts are available.
I've said it once and I'll probably get it tattooed on me.